Hello, I'm Matthew Balti with the Acoustic Neuroma Association, and I'd like to welcome everyone to the 2024 ANAwareness Week presentation of balance issues after AN treatment with Dr. Sarah Grantham and Dr. Kate Lewis of Vanderbilt Health. You can stay up to date with ANAwareness Week and everything the ANA has to offer at anausa.org. Our website is a great resource for so many topics that you may have an interest in. There is a search function so patients can find just what they're looking for. Lastly, keep an eye on our social media pages on Facebook, LinkedIn, Instagram, and Twitter for more information and resources. The ANA is here to help, so please access those opportunities. So Dr. Grantham and Dr. Lewis, if you'd like to turn on your camera and introduce yourselves, we can get started.
My name is Kate Lewis. I am a physical therapist at Vanderbilt in a clinic called Pi Beta Phi, and I work with patients who have vestibular dysfunction and balance impairments.
My name is Sarah Grantham. I'm an audiologist at the Vanderbilt Balance Disorders Clinic, and I specialize in the evaluation treatment of balance disorders.
All right, we'll go ahead and get started.
Well, first of all, thank you so much for the Acoustic Neuroma Association for inviting us to present this important topic. We will do this presentation in two parts, starting out with diagnostics, specifically audiological assessment, and then moving towards rehabilitation with my counterpart, Dr. Lewis, because that's really where the treasure is the recovery and rehabilitation. And so this is how we get to that point by starting with evaluation and then working towards treatment management and rehabilitation. So just a brief bio on my professional and personal experience. I have 20 years experience in audiology, focusing in evaluation treatment of vestibular disorders. I run the Balance Disorders Clinic in Nashville, and we also have a satellite clinic in Franklin that evaluates about 1,800 to 2,000 patients a year. And we work very, very closely with our incredible Pi Beta Phi neuro PT colleagues to help our patients have the best outcome and quality of life, regardless of what type of disorder they're dealing with, and in particular, acoustic neuromas in our school-based centers. I also have firsthand experience as a school-based center patient, not with an acoustic neuroma, but with a meningioma in the cerebellar pontine angle that presented with all the symptoms consistent with an acoustic neuroma. And so as an audiologist, that is what I thought I had, but treatment and rehab were very, very similar, and I had the most incredible team to work with. So I'm very, very grateful, and I can empathize and completely with what all of our acoustic neuroma patients are undergoing. So just a very, very brief introduction, which I think most everybody viewing the webinar is familiar with, is the acoustic neuroma or vestibular schwannoma. The terms are used interchangeably, but it is technically more of a vestibular schwannoma based on histopathology. It's just a benign tumor originating from the Schwann cells within the myelin sheath of the vestibulocochlear nerve. Incidence and prevalence, all of these sources are from the Acoustic Neuroma Association, and the variability of acoustic neuroma ranges, and it's becoming more and more, a little bit more common now that we have advanced imaging, but it can constitute 8% of all brain tumors, 1 to 3.5 of every 100,000 people per year in the United States. So it's a fairly rare tumor, but in our clinics, we see it very commonly, almost every day, certainly every week. We work very, very closely with our school-based colleagues to treat and manage these wonderful patients that we are very privileged to get to take care of. Common signs and symptoms: aural fullness, unilateral tinnitus, asymmetric hearing loss that usually impacts the high frequencies first, poor word understanding in the affected ear, dizziness and imbalance, headache, facial numbness, tingling, and/or weakness. All of these signs and symptoms have been commonly observed in acoustic neuroma patients, but not all patients have the same symptoms. Not all of them have any of these symptoms or all of them. So here's a brief rundown on audiology services that we offer. While we will be focusing predominantly on the vestibular function testing, the hearing side of things is very important as well. So I just wanted to briefly run down that test pattern when patients are diagnosed with acoustic neuroma typically entail a comprehensive hearing test and vestibular function testing, as well as imaging studies. Patients either during or after surgery can undergo a tinnitus evaluation and counseling to work with any onset of tinnitus in their ears, either pre or post-operatively. Discuss amplification consultations if they have hearing loss in their other ear, and cochlear implant workups can also be something that is discussed depending on what type of procedure is done surgically. Moving on to vestibular function testing, we do a very comprehensive workup here at Vanderbilt. It includes 4 primary assessments: video nystagmography, or VNG, the rotary chair test, sometimes called SHA, which is short for sinusoidal harmonic acceleration. We just call it rotary chair to keep it simple. Video head impulse testing, and then the vestibular evoked myogenic potentials are the 4 primary tests that we do in our diagnostic workup. And before we move on to vestibular function testing, just wanted to highlight a description of some of the typical hearing losses that we can see in a patient with acoustic neuroma. So red symbols represent the right ear, blue symbols represent the left ear. And what you can see is this very high frequency loss of function. Usually there's a very significant asymmetry between ears. And that's one of the standard red flags that will indicate the need for further evaluation in patients. Oftentimes when we first see acoustic neuroma patients, they are reporting really annoying or debilitating tinnitus in that affected ear. And so one of the other things that Vanderbilt Health offers is a free webinar discussing living with tinnitus, different options for managing those symptoms. All right, so before we get started talking about vestibular function testing, it's important to just have a very basic idea of how we get that information. All the testing we do is based on reflexes. The most important one is the vestibulo-ocular reflex, or VOR. It is an eye movement reflex that keeps our gaze stabilized with quick head movements. And we have a VOR for lateral head movements as well as vertical head movements. And it's the foundation for most of the vestibular function testing that we do. And it's very important in on the rehabilitation side as well. So the video nystagmography test is a series of assessments under video goggles. They have infrared cameras in them, which allow us to record the eye movements. We screen the eye movement system, or ocular motility, to make sure that there's no eye movement disorders that could prevent our ability to evaluate the VOR. We also screen for any types of positional dizziness that may be present, observing for any evidence of a spontaneous nystagmus, which might indicate an acute vestibular event that is ongoing in one ear, or central positional signs. And then the gold standard test is the caloric test. That helps us to identify any underlying impairment of the peripheral vestibular system affecting the lateral semicircular canal and or the superior vestibular nerve. And so just a little information about what caloric testing is. We utilize either water or air. We irrigate the ear, and that transmits heat. It's the water or the air is just a medium for heat transfer that transfers heat into the inner ear of balance and stimulates the inner ear, triggering an eye movement reflex that causes nystagmus. And we are looking at the strength of that nystagmus or eye movement response, comparing it to the right versus the left ear to determine if one ear is weaker than the other. This testing can induce some nausea or sense of movement or turning. So we do ask patients not to eat or drink anything prior to testing. That usually helps with tolerance. But it's a very critical, important test. And that looks at the lowest frequency function of the lateral vestibular reflex. And moving up into the mid-frequency range, we do rotational chair testing. It's just a fancy version of a swivel chair with another pair of goggles, and it is useful in determining whether or not an inner ear balance weakness is compensated at the central level. It tells us how extensive an impairment might be if both ears are weaker than they should be. And it can also help us identify whether or not there are any central vestibular system impairments at the brainstem or cerebellum level. And then to evaluate the high frequency function, there's this really cool new test called video head impulse test. And just with very quick movements of the head from side to side, or in particular vertical planes, we can evaluate all 6 semicircular canals, the lateral, anterior, and posterior semicircular canals, and identify if that high frequency function is working properly. And that can be really helpful in determining if a patient needs some gaze stabilization therapy with physical therapy, or if they have preserved high frequency function, even if the low frequencies are impaired. So we've talked about all of our angular receptors. Those are our 6 semicircular canals and the innervating nerve branches that connect to them. Next, we're going to move into the otolith organs, which are the linear and vertical receptors. For that, for those structures, we use a test or 2 versions of the vestibular evoked myogenic potential test. Just some fancy terminology for a muscle reflex that's evoked through sound, and it originates in the vestibular system, specifically the otolith organs. And the otolith organs are those velocity and gravity receptors that sense forward and back and up and down movements. So patients with otolith impairments don't typically report dizziness or vertigo so much as unsteadiness. Oftentimes they'll report, I just feel like I'm rocking on a boat. So it's more of a postural instability as opposed to a room spinning vertigo. And so this gives us very important additional information about other structures within the inner ear of balance that we weren't prior able to evaluate. So the 2 assessments, we look at the ocular vamp, which evaluates the utricle and the superior branch of the vestibular nerve, and the cervical vamp, which evaluates the saccule and the inferior branch of the vestibular nerve. And this is very important with acoustic neuroma and other disorders impacting the cochleovestibular nerve, is that you can actually pinpoint, what branches of the nerve is impacted, and that can provide critical information for neurotology and neurosurgery to plan out their surgical intervention if that is the choice of the patient and their healthcare team. And then this is just a illustration of the electrode montage or the setup for the ocular vamp testing. And when we present a sound to the ear, it triggers a change in muscle tone. And for the ocular vamp, the muscle is off and then it contracts. So it's going from an off to an on response. And then when we do the cervical vamp, it's just the opposite. We're recording an on to an off response. So the waveform looks a little bit different. You can see that in the next slide. So just some examples of what to expect if you're referred for vestibular function testing. It is a very comprehensive workup. It provides really valuable information about the vestibular system, what's working, what's not. It's a 2-hour appointment, so it's not short, but it's very, very helpful. And we try to coordinate these appointments to where you do the hearing test, the vestibular function test, and the neurotology appointment all in the same day. Oftentimes, sometimes if patients are coming from a great distance, we'll also try to coordinate a PT consult as well. And then just to wrap things up on the diagnostic side of things, just wanted to highlight the importance of comprehensive care. These assessments, they help with early identification and monitoring of patient status. Oftentimes audiologic test results can help to determine the course of treatment. Are we going to opt for like a hearing preservation surgery, or say a patient has perfectly normal hearing, but they're just terribly vertiginous and quite debilitated by their imbalance. The surgeons might, recommend intervention because of the vestibular symptoms as opposed to the hearing symptoms, and then try to, opt for a preservation type of procedure. And then also this testing helps to coordinate rehabilitation needs for best outcomes. And with that, I will turn it over to Dr. Lewis.
Thanks, Dr. Grantham. I appreciate all the work that you do and all the valuable information that you provide for our patients. It really helps us as therapists to be able to provide the most specific care and best practice. So we are very grateful for our colleagues, our audiology colleagues, and all the work that they do. My name is Kate. As I said, I'm a physical therapist at Pi Beta Phi Rehab Institute, and we work with patients, specifically patients with neurologic involvement. And specifically, even more from that, I work with patients who have vestibular involvement or who are having dizziness and balance issues. I am a neurologic certified specialist, so that means I have advanced training in working with patients who are having balance issues, dizzy issues, and associated symptoms. So I work very closely with Dr. Grantham and her team on rehabilitating all kinds of patients, including those with acoustic neuromas. So in terms of acoustic neuroma rehabilitation, we're going to touch briefly on what it is, because Dr. Grantham did a great job of explaining it. We're going to talk about what the goals are for physical therapy, and then the different types of therapy that would be beneficial for someone with an acoustic neuroma, either pre-surgical, post-surgical, really anywhere in their recovery process. Therapy would be beneficial, and I'll kind of explain how and when we would do that. So we know that with an acoustic neuroma, it can lead to various functional deficits. And because of that, we know that rehabilitation is a crucial part of the recovery process. Again, it's not just post-surgical that we can introduce rehabilitation, but we can work on deficits present prior to any sort of medical intervention. We're going to go over those kind of rehabilitative therapies and goals for patients with acoustic neuroma. We know that acoustic neuroma is caused by that abnormal growth of cells, as Dr. Grantham spoke to, and it can lead to hearing loss, balance issues, and facial numbness or weakness. Lots of different options available based on the presentation and specific location of the acoustic neuroma, including the size and various things. But treatment can include observation, surgery, radiation, and/or a combination of all these things. Regardless of the treatment method, patients will often require comprehensive rehabilitation to address these impairments and functional deficits. So whether someone is coming pre-surgery or post-radiation, it's important to provide a comprehensive look at what we can do to improve their overall functional capacity. There we go. So our physical therapy interventions and goals. So the goal of physical therapy is, we've kind of got three things that we're really working on. So we want to improve balance and coordination. So we want to improve the patient's ability to maintain their balance in a static position and a dynamic position. So that means maybe when they're standing in the shower and they're washing their hair, or they're standing brushing their teeth. Those are examples of static balance. And then when we talk about dynamic balance, it's the patient's ability to move through their world without losing their balance or without experiencing dizziness. So this may be going to the grocery store or walking to a doctor's appointment, but the ability to move through their world and feel stable is really important for physical therapy, one of the goals that we really work towards. We're also making sure that as they move through their world, they do it in a coordinated way that prevents falls and prevents any kind of future injuries as well. We also work on improving their strength and mobility. And so we are, again, when we look at the patient's functional mobility and functional independence, we want to make sure that they can move and operate and do all the things that they want to do at the highest level of independence. So we also are going to work on managing the symptoms of acoustic neuroma. So we're going to use different strategies, adaptation, habituation, and compensation to help manage these symptoms. So an example is if we're getting a patient who is pre-surgical resection of acoustic neuroma, then we're going to work on trying to use the other parts of their vestibular system that are not impaired to help maybe compensate for some of the loss that they're experiencing. Or if they've had a surgical resection, now they have lost some part of their vestibular system. Again, we're going to use a combination of adapting to this new system or this new or compensating, for the loss because of the resection. We're going to use different techniques to help reduce that dizziness and vertigo that the patient may be experiencing. This picture here is a picture of a way that we measure a patient's balance. And so we put this patient on our machine here at Vanderbilt, and we're looking at the way they use the different balance systems. So our balance systems are our eyes, our inner ear, and our sense of touch. And so our inner ear is our vestibular system, but we have two other balance systems and so they all kind of work in a checks and balance way. And so when there is injury to that vestibular system, then we can tease out kind of the degree of functional deficits that are occurring and how we can use the other balance systems to kind of compensate for that loss. It really helps us to measure objectively a patient's balance and how they're improving. So when we look at balance and vestibular rehabilitation, this is kind of a general timeline. It's not always going to be 12 weeks. It may be longer, it may be shorter, but in the first couple of weeks, we're evaluating balance and vestibular function. And so the way we work really closely with Audiology is they help provide us kind of diagnostically what's going on and what impairments and deficits that the patient has. And then they come and see us in physical therapy, and we see how those impairments are impacting their function. And so we evaluate, again, their standing balance, their walking balance. We evaluate their gaze stability, how they're able to keep their eyes fixed on a target. We look at all these things and we're able to measure and track progress as we move through the rehabilitative process. In the weeks 3 to 6, we are developing a program for our patient. Again, really hitting those areas of adaptation and habituation. We're working on improving and utilizing the parts of the vestibular system that are not impaired by the acoustic neuroma. And we're progressing through various tasks and functional activities to improve the patient's independence. And so that may include doing exercises on uneven surfaces, or walking with head turns, or navigating complex environments, all working on, again, maximizing that functional independence and reducing dizziness. And then in the later stages of recovery, we're increasing those challenges. We're increasing the patient's ability to maintain their gaze in complex environments. We're going to challenge them aerobically, get their heart rate up, and we want them to be able to participate in their world and go to the grocery store, or go to church, or go to activities that are complex. And we want the patient to be able to do that in a way that is safe, doesn't cause any increased instability or falls, and again, maximizes that independence. So some of the things that we will do, some of the exercises that we will evoke include gaze stabilization exercises. So you think back to what Dr. Grantham was talking about with the vestibular ocular reflex. That is a function of a person's gaze stability. So we are going to take the information that Dr. Grantham gave us about the patient's vestibular ocular reflex, and we can improve, in some instances, we can improve on that. Essentially, what we're doing is working on stabilizing the patient's gaze when they're moving through the world. So we want their eyes to be able to stay fixed on a target while they turn their head. Some of the complaints that we hear is, when I'm driving my car and I turn my head to look and see if traffic's coming, I feel really dizzy. Or if I'm walking through the grocery store and I'm scanning the shelves, I look really dizzy. Those are all functions of the vestibular ocular reflex, and in those instances, that reflex is impaired. And so we introduce these gaze stabilization exercises to help improve how the eyes are able to stay fixed on a target. We'll do visual motion exercises to help the eyes and head work together when the head is moving, so that a person can move and turn their head and exist in the world and not have those dizzy feelings, and be able to tolerate complex environments. We will work on standing and dynamic balance exercises. Again, we're working on improving the way that other balance systems are working with the brain, as well as using the remaining parts of the vestibular system that are present, using the brain to kind of incorporate that information a little bit more effectively. We want the brain to kind of organize the balance information and integrate it more effectively to help preserve balance. So sometimes a patient will have some damage to the facial nerve, or will have some facial weakness or paralysis, and so they will need facial rehabilitation. And so there are specialized physical therapists who can do that. We do that in our clinic as well. And so the physical therapist will evaluate the extent of facial nerve damage. And again, we'll develop a customized rehabilitation process to address the needs of the patient. There are specific exercises that they can implement to help with improving symmetry of movement, improving coordination and tone, so that we can recover some lost movement. We can also use electrical stimulation. And what we're doing there is to kind of jumpstart or re-educate the facial muscles to help with nerve regeneration. So there's been a lot of research out there to show that that is beneficial in getting some movement and some sensation back in those facial muscles. And so facial nerve rehabilitation is, as I said, treated by a specialized physical therapist with experience in that. Sometimes patients will have swallowing and speech difficulties because of the acoustic neuroma, or because of the surgery associated or radiation associated with treatment. And so then they would be seen by a speech therapist. A speech therapist is going to do a swallowing evaluation to see how the individual is swallowing, and is swallowing liquids as well as solids, and see if there's any interventions that are needed to address that. And additionally, a speech therapist can help with speech and communication. It's in their name. They're going to help come up with a specialized rehabilitation program for individuals who are having difficulty communicating, and help them again to maximize their functional independence. And then lastly, we're going to work on improving strength and mobility. So as we're improving balance and as we're reducing dizziness, we want to as I've been saying, maximize that functional independence. And so as we're working on your gaze stability and your balance, we're also working on improving the strength, improving your cardiovascular integrity. We want to make sure that you can go on walks with your partner, and you can walk on uneven surfaces, and you can get back to the things that you really enjoy, and you can do it in a way that is safe and promotes your overall health and well-being. And so in conclusion, rehabilitation for acoustic neuroma, regardless of where an individual is at in the recovery process, is comprehensive. We're going to address balance, and we're going to address any dizziness or vertigo that's present. We're going to assess facial function and swallowing, strength and mobility, and speech as well. All of those will be components of an individual's plan of care, but each individual will have a specific set of needs that they need to be addressed, and your therapy team will be able to address that and will work towards maximizing your independence. Our goal is always to improve your quality of life. So we want to work with our patients to know what's important to you and what are things that you want to get back to, or what are things that maybe this acoustic neuroma have kept you from, and how can we get back to that in a way that is safe and is functional and maintains your high quality of life. So that's all we have in terms of diagnosis as well as treatment. Our contact information is listed here on the slide. So if at any time you have any questions or concerns, or something's not clear, please reach out to us and let us know, and we'd be happy to answer any questions or point you in the right direction of someone who we think can help.
Fantastic. Dr. Lewis, Dr. Grantham, thank you so much. If you want to go ahead and stop sharing your screen, we'll get to some questions. Perfect. Awesome. So a lot of questions we have pertaining to balance and therapy and things of that nature. And the first one kind of goes off the timeline that you had shared a little bit earlier. This person says that they're pretty early in their vestibular therapy, going twice a week, but right now it seems that things have gotten worse. Is that just a thing of sometimes things get worse before they get better, or that might be a sign of a new normal?
That's a great question. When we talk about timelines and we talk about how long something takes, we always get, patients like, when am I going to start to feel better? When am I going to start to notice these improvements? And the timeline I usually look at is about 4 weeks. And we say 4 weeks is because that's how long it takes the brain to make the necessary neural connections in order to see some improvement. And then in terms of muscle and strength changes, we're looking closer to 5 to 6 weeks before we start to see some real tangible improvements. Now, patients may experience improvement sooner than that, but that's kind of the watermark of, is what we're doing making a difference? So if somebody's been in therapy and it's just been a few weeks, it is possible that they may feel temporarily worse, and that's because we're asking them to do some things that maybe have been uncomfortable or maybe they've avoided, such as head turns or such as moving, testing their balance in a way that they haven't really engaged in. If they are still having issues at 4 to 6 weeks and things are progressively getting worse, or they're certainly not getting better, then it may be, a conversation needs to be had with the therapist and maybe the audiologist, certainly the referring physician, about, we're stalling, we're plateauing a little bit. Do we need to change the exercises, or do we need to reevaluate from a medical standpoint and see if there's been any changes?
It can always be challenging if we have some sort of setback. We're definitely worried that might be a trend rather than an outlier. Does the intentional severing of the vestibular nerve during AN resection affect balance outcomes post-op?
Yeah, yes. I think the short answer is yes. We're getting reduced input to the brain about where the body is in space. But I often say it's not permanent. It's permanent and it's not permanent. It's a permanent fix, But the brain and the body have such a system of checks and balances that there are other areas of the brain that are able to take over and kind of take up the slack for what was done. We often say that the brain is very plastic. And what that means is the brain is able to adapt to various changes that happen in a way that still helps the individual exist in their world. And so it's a permanent, but not a forever change. It's certainly, it's permanent. We can't go back and fix a resection, but we can still improve balance and build upon what is still present to help maximize function.
Great.
Dr. Grantham, do you have anything to add to that?
No, I think I was nodding away because that's exactly what I was going to say. And, in the balance disorders clinic, we deal with a lot of patients who have vestibular disorders for various reasons. Sometimes they've had some sort of virus that inflamed the vestibular nerve and cause complete loss of function. And so, patients have very similar loss of function for other reasons, not because it's a post-surgical resection, but because there was a nerve with permanent, a neuritis that inflamed the nerve and caused permanent loss of function. So for various reasons, you can, lose complete function peripherally at the end organ level and rehabilitate the brain at a central level to where, you're functioning near baseline before, the insult or injury occurred. So the brain is very powerful, and our physical therapists are miracle workers.
We're just bossy.
Well, that's okay. Sometimes you need
we have a lot of patients who understandably want to know the best that they can do between appointments that can help them, between appointments with PT or their doctors to help them with a variety of things. So do you two have any recommendations on exercises or things they can do at home to either help with balance or with speech or any of that facial rehabilitation?
Yeah, I think absolutely. And I think you ask any PT and every answer is going to be the same, is it do your exercises. But I will say, yeah, do your homework. In terms of the various systems in the body, I would say the vestibular system, more than any system, responds the best to consistent stimulation. And so what I mean is, I'm a little biased because it's what I work in, but those patients that I see who consistently do their exercises every day, even at the prescribed prescription, it's usually 2 to 3 times a day. And we're talking 10 to 15 minutes at a time, max. We're not a long period of time, but those patients that consistently challenge their vestibular system get better faster. It's kind of full stop. And that's because the vestibular system is getting consistent stimulation and the brain is recognizing, oh, there's a problem here. And so then it can make the necessary changes. We call it an error signal. And it's just because the brain recognizes, oh, there's a problem and I need to make changes. And the more that you engage that system, the faster you will see results. And that's going to be true from a facial exercises standpoint, balance exercise standpoint, gaze stabilization exercise standpoint. In terms of specific exercises, it's really hard to give here's a one and done exercise that's going to be the most beneficial. I would say you really need an evaluation from a physical therapist to say these, here are your deficits, here are your exercises. Because as Dr. Grantham pointed out, they could have an otolith impairment where maybe they don't have as much dizziness, but they have a lot of imbalance. And so their exercise program is going to be really specific on addressing the balance impairments. Well, then patient B may not have otolith impairment, but they may have facial nerve palsy. And so then that patient is going to get more facial exercises. So it's really specific to the patient. But I will say, by and large, my patients who consistently engage in the exercises get better faster.
And somebody also brought up doing yoga. Could getting into yoga leading up to your treatment and then obviously also doing it after, does that play any kind of part in kind of helping with those exercises and helping regain that balance?
Yeah, we love yoga. We love yoga. At Pi Beta Phi, we love Tai Chi. We are big fans. And so absolutely getting involved in some sort of yoga, Tai Chi, some Pilates even, is fantastic. Obviously do it in a way where you feel safe and you're not going to put yourself at risk of injury. But yeah, absolutely. Because what it does is it starts to get the patient more aware of how their body is moving, and also teaches them that it's okay to move their body. That's one of the things that we really emphasize a lot, is that, you may get dizzy, you may get off balance, but it's going to go away, and it's okay to move your body. Let's do it in a way that's supportive and maximizes independence. So the short answer is yes, we love that.
Great. And we've got time for one more here. This person seems pretty active. She talks about when going hiking, she's noticed that the slower I go, the less stable I am, and that actually looking forward down the trail helps with her balance and dizziness. Is that a good understanding of kind of how to go about moving around more like that if you've got those balance or dizziness issues?
Yeah. I would absolutely agree that sometimes we can almost move too slow, that we are actually putting ourselves in a position of increased instability. The body is a machine. And so as a machine, the body likes repetitive, consistent movements, likes rhythm, likes reciprocity. And so when you're moving at a consistent speed, one foot over the other, that's actually going to feel a little bit more stable. I would also encourage that person to look into trekking poles. Sometimes cane and walker are dirty words. Some patients don't want a cane, don't want a walker. And I hear that, I get it. But I think trekking poles are a really good place to start, because they can provide another point of contact and almost just give the patient a little bit more confidence in their movements. So I would tell that patient, continue being active, because that is stimulating your vestibular system, and that is really important for recovery. But maybe get a trekking pole or two to kind of help with some confidence.
I love mine. I still use mine.
Yeah, trekking poles are great. We love them.
That's right. Awesome. Well, Dr. Grantham and Dr. Lewis, thank you so much for your time today and all the wonderful information. And thank you for the ways that you help a variety of patients and AM patients as well, and for the partnership we have with Vanderbilt Health. We're so grateful for that partnership. So thank you so much. And thanks everyone for watching. And be sure to go to anausa.org and our social media pages for more information.
Thank you.
Thank you so much for having us.
Yeah, thanks. Take care.